We're ready to go. So, hi, welcome everybody. Thank you for attending this little lecture here. I'm going to talk about the bedside lung ultrasound in an emergency. I'm Dan Livingston. As you just heard, I'm from Indianapolis, just translocated here to do fellowship, third year Palm Critical Care Fellow. So we've met each other and we will interact with each other in the future. So as you know, in the MICU, we promote the use of ultrasound quite often with thanks to some of our faculty who are staunch advocates of bedside lung ultrasound or bedside ultrasound in general, and in collaboration with with emergency medicine. And we're kind of strengthening our teaching in bedside ultrasound. So today we're going to talk about the Blue protocol, the bedside lung ultrasound in emergency, which you may or may not heard of, and you probably do to some extent use this and the features thereof, but maybe haven't heard the entire protocol or methodology of it in its entirety. So I just want to review that with you. And the main premise for using the bedside lung ultrasound is because our standard methods of assessing a patient in respiratory distress have very low sensitivities and specificities, and namely with the use of your stethoscope and chest X-ray. And as we all know, the advantages of ultrasound, now that it's become more portable, have become manifest. So moving on, the bedside lung ultrasound protocol with the was designed or developed rather in France in the early 1990s, and it took some time, maybe 20 years, for it to really become commonplace. And today we want to go through the objectives, and the objectives I want to focus on here are: one, probing your patient. And probing your patient meaning don't be afraid to grab a probe for your ultrasound, and encourage a methodological approach to your ultrasound techniques, identifying those artifacts and appreciating the shortcomings of Blue and shortcomings of ultrasound in general. The outline here, we'll go through an intro question, we'll go through a couple of cases, and with these cases, we will focus on specific portions of the algorithm itself. Now, my first question to you is, which probe do you like to use for lung ultrasounds? And I'll start with you, if you don't mind. Which probe do you grab when you do a lung ultrasound?
It depends on what I'm looking for.
Okay, great.
If I'm looking for low sounding, I go for the linear probe. If I'm looking for something deeper,
sure.
to use the linear.
Mix it up, sure. And that's what they did with that's not what they did with this particular study, with the lung ultrasound study, but they used a small convex probe, which we don't standardly have in the MICU, and you may have a small convex probe in the ER, I'm not sure. But you have your phased array, your linear, and your convex probe. All of which are sufficient, of course, depending on exactly like what you said, what you're looking for. For your bedside ultrasound, you can commonly go for a convex probe, whether it be a small or large, like you see pictured here. I personally go for the large convex probe because it will allow me to do an abdominal exam as well. It allows me to go back to the posterior aspect of the chest without having to switch out probes. So it's just a more, I guess, practically efficient way of using the ultrasound. But again, it is up to you. There's no standard approach here with regards to your probe. So the question is, where are you going to place this probe, and what are you looking for when you place it on the chest? So let's look at the history. As I alluded to earlier, we have 200-year-old technology that we carry around with us daily, and that's in the form of a stethoscope, which was developed in 1816 by René Laennec in France. And he used this, and then about 90 years later, we have Röntgen, who developed the X-ray, incidentally developed the X-ray. And then we have, in 1956, the first use of the ultrasound, as we know ultrasound to be today, in Scotland, with two OBGYN docs who were using an amalgamation of this technology and the physical laws to create an ultrasound picture in the field of OBGYN. So the technology thankfully has developed and evolved to the point where we can use it. Now, a fun fact here, the Titanic sinking actually played a large role in the development of the ultrasound. Why? Because after the Titanic sank, a hydrophone was then developed in order to detect icebergs up to 2 miles away. It wasn't very directional in a sense, but the sinking of the Titanic in fact spurred the development, or kind of pushed along, moved the ball down the field, if you will, for the development of what we know ultrasound to be today. And then in 1992, the Blue protocol was developed in France. And then in 2005 and then subsequently 2015, we had a review article for the Blue protocol in the Chest Journal. So in essence, 200 years later, we have now a protocol devised for assessing the chest and for patients in respiratory distress after the development of the stethoscope. So how was this particular the Blue protocol, how was it developed? Well, 260 patients were studied in France for those who had respiratory distress, and who were admitted to the ICU. And of those patients using this protocol, about 31% of those patients were found to have pneumonia, others pulmonary edema, COPD, asthma, PE, and pneumothorax. Those are the main diagnoses that they came to with the use of this ultrasound. Now, they did not have any history. They did not have any laboratory data. So you're going in it blind. Patient who's in respiratory distress, you throw a probe on their chest and you can identify one of the main causes of the respiratory distress. Now, what was the diagnostic accuracy of those? 90.5%. 90.5% diagnostic accuracy without any history or labs, just based on ultrasound alone. Therefore, this protocol was considered a robust, was considered robust enough to be used in diagnostics. So that's cool, Dan. So what about it? What is this protocol that you're talking about and hyping up? Well, this is the protocol. And forgive me for giving you an algorithm like this, but you're not supposed to, standardly a purist who's doing presentations, you're not allowed to, give a slide like this. It's so busy that it just confuses everyone. But we'll just walk through this particular algorithm together. As you can see, however, in blue, you have your main diagnoses that you're primarily looking for just by use of the ultrasound. And that is pneumonia, pulmonary edema, and pulmonary embolism, asthma, COPD. So, and then pneumothorax, of course. So those are the main ones that we're really focusing on. Let's say we have a VIP patient, his name is SpongeBob, and you are giving a tour to some unsuspecting residents or candidates in the ICU. Somehow you find yourself in the ICU, and suddenly the nurse runs out of a room saying that a patient is suddenly hypoxemic and hypotensive, and you don't know where to turn. You're the only one he or she sees, and then you ask, well, where's the fellows? And she says, well, the fellows went off to get smoothies. Well, where are the residents? Well, they're at a meeting. So you're left with your own devices, and you have these candidates with you, so you want to show off, right? So then behind you, staring at you, is the Philips Spark. And so you just grab a probe and you move on to the patient's chest to identify what's going on. But what are you going to do before then? Well, maybe you'll grab your 200-year-old technology stethoscope and listen to the patient. And I'll tell you that they have diminished breath sounds on the right, and they have you can hear breath sounds on the left. Great. So then you ask for a chest x-ray, but your chest x-ray isn't available because it won't pull up an epic, but you can see the read, which says that this patient has bullous emphysema. And then they're put on rescue BiPAP. They were just admitted, I forgot to mention, just a few hours before you saw them, and they're put on rescue BiPAP, and now they can't breathe. Right, so your chest x-ray. Well, you call for a stat chest x-ray, and what does the tech tell you? Well, I'm on the floor. I'll be there in about 5 minutes. You don't have 5 minutes, but you do have a Philips Spark available. So you grab your probe, whether it be the linear probe or the convex probe or the phased array probe, doesn't matter. Grab your probe, and you put it on the chest. And this is what you see. You see lung sliding, right? We can all agree this is lung sliding. And this is on the left side of the chest, where the blue box is. And next, you're going to put it on the right side of the chest, looking at the upper and lower thoracic points. It's loading. Yes. Upper and lower thoracic points, and you identify no lung sliding. And this is going to be your upper thoracic point up here. Now, what if we go to the next one? Well, at the next one, you're going to identify, what is it?
Lung point.
Lung point, yes. So you're going to identify a lung point, and this is at the lower thoracic point. And you're kind of getting the idea with this blue protocol. You've got 3 thoracic points on each side. You have your upper, lower, and then you have your PLAPS point back here. So we identify lung point, and therefore we've diagnosed a pneumothorax. And in the original study of 260 patients, about 3% of cases were pneumothoraces, but it is probably the most what would we say, acute and dangerous diagnosis, and so therefore important to identify. So you've made your diagnosis just based on that. So grab your arrow dart and show off for the candidates. But do you need to wait for a chest x-ray? Well, you could, and your chest x-ray would show you this. Now, this isn't the actual image of SpongeBob, of course, because it's not square, but you can identify the fact that he has a large pneumothorax. And in the upper thoracic point, you have some collapsed lung there. So of course, you're not going to identify the pneumothorax up there. You have collapsed lung, but you go to your lower thoracic point and you will identify your collapsed lung. And these are the points that I want to look at. So in essence, what you're looking for is A, sliding, and B, a profile. So in that profile, you're going to identify either A lines, B lines, or C lines, which you hardly see. So again, in that algorithm, if I go back, in that algorithm, you notice at the very top, the first thing you're looking for is lung sliding, and that's what you're looking for when you grab your linear probe, and that's great. And then the next thing you're looking for is that profile. Is it A, B profile? And as we saw in that particular case, it was an A profile. I'm not going to review it. Let's just continue now. All right. So so how can you be sure there's no lung sliding? Well, of course, we identified the fact that there was no lung sliding, but to be absolutely sure, you can go to real-time imaging, that is your M mode, to look for this stratosphere sign. And the lung sliding is going to occur at the level, of course, of the pleural line. Now, Jackie, can you tell me, the pleural line, does it represent the parietal pleura or the visceral pleura?
No, the front.
Got it. Parietal pleura. Always the parietal pleura. Got it. And of course, if the visceral pleura is abutting that line, then it's going to be both. But in all cases, it's considered the parietal pleura. Now, it's often very discrete, and in which case you may be sure if there's lung sliding there. Those ants are crawling, as they like to say, but in which case you can just switch over to your M mode, which takes an extra few seconds, and identify whether or not there's any lung sliding. And in this case, with that barcode or stratosphere sign, we don't see any lung sliding. And between the arrows there is your pleural line. So this is what's called, somebody please tell me what this sign is called. Thank you, seashore. Yes, so you have alveolar gas that is identified here in the sand. I'm sorry, in the sea part. and the sand, or the beach rather, is going to be the barcode of soft tissue you see on the upper portion. And you see the black arrows there corresponding with your parietal pleura here, or your pleural line. There. So this is normal. All right. So we are seeing normal lung here. This is your seashore sign. But I want to bring your attention to the use of the MO, especially in the case of a pneumothorax. So you identify what's normal and what's abnormal. So note that here, note that in the left panel, you've got your A lines, which are a repetition artifact of that pleural line. And of course, those A lines are going to be equidistant to each other. And then in your panel on stage left, or your right-hand side, you're going to have your pleural line where the visceral pleura appears. So the visceral pleura is going to appear here, so it's showing you the C, and then you have free gas in the chest over on the right-hand side, which is part of that stratosphere sign. And this is your lung point, because it's coming to a point here along that vertical line. All right. This is your normal lung pattern on the left. This is your stratosphere sign, where there's just gas, free gas in the chest wall, and then that is your lung point, which you would see on the on your M mode. Has anyone diagnosed pneumothorax using the M mode like this? Have you identified? Yeah, it's pretty easy to switch it over there and take a look. We had a particular patient in the ICU a few months ago who had COVID, pneumomediastinum. He then developed a tension pneumothorax, and it was a very similar case as I described, where like with SpongeBob, you are suddenly in the ICU, and the nurse comes out saying this guy's hypotensive, hypoxic, and you throw a probe on, and you see that lung point. You don't forget it once you see it. It's really memorable. So if you don't have any lung sliding, then what should you consider? Of course, pneumothorax or pneumonia. In which case, if you had pneumonia, then you do have parenchyma under that parietal pleura, right? And in which case you're going to see B lines. And in the algorithm, it says B prime profile. That is a fancy way of saying you don't have lung sliding, but you may have some B lines in there. And the A prime, again, you don't have any lung sliding, but you have A lines. So that's what the prime indicates in the algorithm itself. No lung sliding, let's consider pneumonia, pneumothorax, just an easy way to think of it. So the question is, what are B lines? What make up these B lines? Can someone give me a differential for absent lung sliding? And we can start off with pneumothorax. Sorry? Oh, that's a good one.
Already intubated.
Yes, yes. Apnea, yes. Exactly.
I hope you're not diagnosing apnea.
Or, I mean, and an extension to that is if you tube the goose and the patient remains paralyzed, you're not going to have any movement. So as esophageal intubation following RSI, where the patient remains paralyzed, or main stem intubation or occlusion or poor respiratory effort, as I said, it's very discreet sometimes, especially in the upper lung field, to see that lung sliding, in which case your M mode really helps. And pleural effusion, inflammatory adherence like an ARDS, pleural fibrosis, which we'll most often see in the unit. And so that's things to think about if you don't see any lung sliding. Most importantly, pneumothorax or tubing the esophagus, of course. So let's just talk about B lines really quickly. And when I think about B lines, I think about the rays of light that shine through water. And in this particular image, you can imagine the boat is your probe and the B lines are the rays of light underneath. Of course, we don't have sharks and fish and scuba divers in our lungs, but it's just a kind of an interesting way of thinking of it. Now, after you establish whether or not there's pleural sliding, then you want to see which artifact is under the surface. And that's what this particular image represents. You've established lung sliding, plus or minus lung sliding, and now you want to look at what's under the surface. Are they A lines or B lines? And specifically B lines. So in the mid-90s, Daniel Lichtenstein, who is the father of sort of bedside lung ultrasound, established for the first time that there are two main structural correlates to those B lines. What are they? Edema and fibrosis. So and he correlated this data with CT scans. And it showed that B lines were very correlative to thickening of the subpleural interlobular septae in case of interstitial edema, and to fibrotic thickening in the case of pleural fibrosis. So the B lines therefore represent edema or fibrosis. And then in the early 2000s, B lines were then validated as a finding that correlates with the degree of extravascular lung water. So there's a correlation between your amount of B lines and the extravascular lung water. So here we have our image again of the two thoracic lung points on your right-hand side. on the screen's right-hand side, and then a correlating CT scan followed by an ultrasound image. And you can see up here is where your probe is on the upper left-hand corner of the CT scan image. So the name of the beeline artifact is also known as a comet tail artifact. So you may often hear of it as being a comet tail artifact. You may hear lung rockets, but they are beelines. And these are long comet tail artifacts arising from the pleural line, as we just established. And multiple lung rockets here in the ultrasound image are seen just about 3 millimeters or so from that pleural line. And that is representative of that ground glass opacity you see in the right upper lobe. And you can identify it as a ground glass opacity because of the way the beelines look. They're not very discrete beelines. There are multiple beelines, like over 5 or 6 of them maybe, and they kind of coalesce together. And I'll show you in this next one then, you have, if you bring the probe down to that lower thoracic point, you have thickened interstitial or interlobular septae, in which case you have more discrete beelines, or they're more defined beelines. And again, this is shown in thickened interlobular septae, which you would find in also edema or pneumonia. So there's a clear difference between a ground glass opacity beeline and thickened interlobular septal beelines. So the beelines are going to be present normally anyway, especially maybe not anteriorly, but definitely in the more dependent part of the lungs, right? We've all seen this, that, you know, patients are generally don't have much lung pathology, and you're going to see some beelines. And generally it's in like elderly folks and or at the lung bases. So less than how many beelines is considered normal? Can you tell me? Correct, less than 3, exactly. So that's considered normal, and especially in, like I said, elderly and posteriorly. Now, an A line is comprised of multiple little horizontal lines. It's like a stack of coins, if you will, multiple horizontal lines. And when you see these B lines, these are just indicative of air fluid interface and the waves bouncing off that air fluid interface. So you're going to see what's called a J line in your B lines. Sometimes you'll see them, sometimes you won't. And this represents air fluid interface. And also B lines will erase your A lines. As you can see here, B lines erasing those A lines. This pattern is reminiscent of a rocket liftoff, hence the practical term lung rockets as well. Now, as I mentioned earlier, the amount of B lines is going to be correlating with the amount of lung water. So, and inversely related to the amount of air you have in the lungs. And that's what this slide demonstrates is you have a bunch of air, you have no B lines. You have more fluid in the system, or more fluid, extravascular lung water, and then you create more B lines, and then eventually with consolidation or hepatization of the lung, you're not gonna have any B lines either. So this is correlating with the amount of air. It's inversely related to the amount of air you have. So what causes our B lines or the comet tail artifact? As we said, it's an interface between air and fluid. So again, your B lines, they may slide, they may move, or they may not move with the pleural line. It's not a definite. And it's also known as a hyperaeroic artifact, interestingly enough. That's kind of a new term I learned. So let's compare the B lines to the other artifacts. We already saw A lines. We just kind of dove into B lines. And C lines are another artifact you may see under the surface. And this is simply consolidation in the subpleural space that you may see, which is directly correlated with pneumonia itself when you go back to the algorithm. So in A, you have normal aerated lung with that repetition artifact, A lines, and B, we just talked about with the air fluid interface. You're going to see pulmonary edema, you're going to recognize pneumonia, or consolidated lung if you see C lines. And again, these are all going to be seen anteriorly. You can diagnose these conditions anteriorly with those upper and lower thoracic points. Again, CT corresponds corresponding with those findings. And like I said, in the algorithm, you may or may not have lung sliding, but if you see B lines, then you're talking about edema or pneumonia. All right, so do you need to have lung sliding bilaterally? Or what if it's absent on one side? If it's absent on one side, then you've got a problem, as we just talked about. Absence of lung sliding, especially bilaterally, if you've got apneic patients, you've tubed the goose, or or your patient's paralyzed for some reason. All right, so let's get off of that. As I alluded to earlier, you establish your lung sliding. That's stage 1. Stage 2, you're going to establish your profile, and so you want to see what's under the surface. Now, where do we go with this? What's our next step? Our next step, we've looked at the anterior chest. Now we want to go back around to the third point. The third point is what's called your PLAPS point. And forget your name. Can you tell me, Spencer, can you tell me what PLAPS stands for? It's an acronym. Posterolateral alveolar pleural syndrome. It's a mouthful, so that's why we say PLAPS. Okay. Before we go to PLAPS, I just want to reiterate that anteriorly, you can identify these conditions just based on your lung ultrasound on the upper and lower anterior thoracic points. So if you have the A profile, you can bring in anything that doesn't require or consist of pathology within the parenchyma. So COPD or asthma, you may have a PE, you may have pneumonia that's hiding laterally, posteriorly, or posterolaterally in your PLAPS point. If you have that B profile where you've got the B lines, then you're looking at pneumonia or pulmonary edema, and you can pretty much can't rule out. You can like diminish on your diagnosis a PE and definitely pneumothorax, because you've got parenchyma clearly with those B lines, so you don't have a pneumothorax. And then your AB profile, I did not mention this, but you could have A on one side, B on the other side, in which case you have pneumonia on one side. Now, this is the C profile where you have consolidated lung here. This is the right middle lobe, which is totally consolidated. That's hyperechoic there. And you have this kind of shredded sort of appearance in the hyperechoic areas where the arrows are pointing to. And Dr. Tabbitt, remind me, help me out here. Would this be considered a ring down sign?
Yes, it's kind of the same concept as giving you that the B lines, up at the lower surface, the air fluid interface. You're seeing that kind of the periphery of that consolidation. Yeah. It's like you have some consolidated stuff, and then the less consolidated, but still like edematous interstitium. Okay. So that's another artifact within an artifact. It's kind of cool. As I mentioned earlier, you have your upper and lower thoracic points. We just walked through that. And now if you don't see any pathology here anteriorly, you can just move around to the back, and you can move around to the posterior axillary line along the horizontal line about the fourth intercostal space. So where that lower thoracic point is, you just move right on around to that posterior axillary line and look back here, the most dependent part of the lung, like we do in most of our patients. You just throw a probe back there and they kind of get uncomfortable and like, don't hurt me. And but you really want to see what is hiding back there at the in the sulci. So you will then identify the you look for your diaphragm, you look for your lung, you look for effusion and all the rest. This is what we call the PLAPS point, the posterolateral alveolar pleural syndrome point. And in the blue protocol, we talked about the main diseases, pneumonia, heart failure, pneumothorax. You can see those anteriorly, but what about COPD, asthma, PE? Those are not seen, but inferred when signs for the others are not seen or they're ruled out, essentially. And again, with your accuracy, your diagnostic accuracy of over 90%. Okay. Can someone tell me, when we look at the upper and lower thoracic points and we see this, what do we see? Do we have lung sliding or not? I'm going to tell you, actually, we have lung sliding here. And now, what do we see? What profile do we see here? A profile. So we have lung sliding, we have the A profile. That's normal. Now we go to around the corner to the PLAPS point, because this is normal up here, but our patient is in respiratory distress.
And what do we expect to see at this collapse point if they're in respiratory distress? Maybe nothing. Maybe it's normal too, in which case you would consider something intravascular like a PE or COPD or asthma, which you would pick up on with other diagnostic kind of workup anyway. And this is the part of the algorithm we're going to go down. And this is what's called the Nude algorithm, or the Nude profile, as they call it, because everything is normal. And then at the end of the day, you've got COPD or asthma. And there's nothing parenchymally that you're going to be able to see with the ultrasound. So that's another term to throw in your basket. So again, we're starting with lung sliding. We go to the profile and then we go to the collapse point. That's the point. And my modification is, if you notice in this particular algorithm, they say if you're normal here in the thoracic points, then you should do a DVT scan and then go back to the collapse point. And I say, no, it doesn't make any sense because I've got a abdominal probe in my hand. I'm not going to switch probes to look at the veins here and then go back. So I can just move on around to the posterior aspect of the chest, look at that, and then go to the veins. That's Dan's modification. It might not be yours. So what do we see at this point? What do we expect to see? As we mentioned earlier, we see a fusion, we can see consolidation. And in this particular case, you have your ultrasound probe here, and this is what you're going to see. And in this particular field, there are 4 anatomical features you want to identify to ensure you're in the right spot. 4 anatomical features. One is the chest wall at the top, the diaphragm on the right, your posterior chest wall here under the effusion, and then a lung. So those are the 4 anatomical features. Now, you want to look for dynamic changes within this space. You want to look for the diaphragm moving down when the patient breathes. You want to look for maybe some swirling inside that effusion. You want to see what's like floating around in that effusion. Remember in that picture, we had some sharks and some scuba divers. You may not see that, but you may see some debris in that effusion. And you want to see also that arrow is pointing to air bronchograms. You may see some changes there. Can somebody tell me the diagnostic accuracy of lung ultrasound with a pleural effusion, with the alveolar consolidation, alveolar interstitial syndrome? As you can see, in the original study, they noted that auscultation for pleural effusion had diagnostic accuracy of 61%. And chest radiography had 47% diagnostic accuracy. Can you guess what ultrasound would be? Well, it's got to be at least 75% for alveolar consolidation. That's 75% for chest radiography. So wait for it, 90%. In all cases, you have over 90% diagnostic accuracy with lung ultrasound in these particular cases to diagnose pleural effusion, alveolar consolidation, and alveolar interstitial syndrome. So the question is, why do we use our stethoscopes? I don't know. Tradition and because it's just convenient, you can carry it in your pocket. You can't necessarily carry an ultrasound in your pocket yet. I want to go through principles. All right, so the main 7 principles of that Lichtenstein appreciated or identified with this particular study are: 1, to keep it simple. You've heard the acronym KISS, keep it simple, scholar. That's what they wanted to do, would keep this idea simple because it requires just one probe for all these thoracic points, and then to keep it superficial, with the idea that almost all acute life-threatening disorders are going to abut the pleural line. So keep it superficial, and then thirdly, just watch the upper part of the pie here. You'll see new pie pieces coming in. So we've got thoracic points, as we identified. The lung is the most voluminous organ in the body, unless you have somebody with hepatomegaly, in which case you could argue. But you have, and so you can identify, or you can pinpoint, like, standardize your thoracic points because you have consistency. of that organ. Pleural line is next. Know that all signs arise from the pleural line. Remember, we talked about the probe, which is like the boat in the water, and then you see A lines, B lines, or C lines from there. So identifying your pleural line is key. Identifying lung sliding also. The lung is a vital organ and signs arising from the pleural line are foremost dynamic. So it's appreciating the fact that you have dynamic changes. Artifacts, these are static signs that are mainly artifactual. So knowing that we have artifacts. And then the seventh most, I like, this is my favorite actually, is the fact that your air rises and fluid falls to the floor. If you have a pneumothorax, it's gonna rise up here. If you have fluid, it's gonna hide back here. So these are the 7 principles to keep in mind when you're doing lung ultrasound. Let's go to the third case. So plankton. Plankton feels puny. Okay. So Plankton is a 40-year-old male with type 1 diabetes, poorly controlled, frequently admitted for DKA, has poor dentition, presented the ED with constitutional symptoms of malaise, fatigue, fever, recently had right-sided pleurisy with shortness of breath. And he feels upset because he feels lousy. Now, you know what? Notice diminished lung sounds on the right with some egophony, and on the left, it's unremarkable. He's tachycardic and febrile. Chest x-ray is ordered, but the tech was called to a stat portable x-ray in the MICU because of a pneumothorax. Now, the Phillips spark is parked just behind you or it's just down the hall, so you need to grab that and identify what's going on with this guy. Again, no imaging, no labs. All you know is that he feels puny. Keeping in mind our principles, we want to keep it simple. We want to know if there are any superficial findings. Identify our thoracic points, upper, lower, and PLAPs. Look at the pleural line, see if there's any sliding in it. Look for artifacts underneath it. And remember that air could be up here or fluid is going to be down here. Now, let's come back to plankton. We have our anterior thoracic points. We have lung sliding A lines for both upper and lower thoracic points, but we need to look posteriorly. And this is what we see posteriorly. And this is with a butterfly. We see good lung sliding there. That's good. At the upper and lower thoracic points. And we see A lines. So again, this is that nude profile, if you will, where we have good lung sliding, we have A lines, so that's all normal. So now what do? We go around to our PLAPS point here. And we identify, we need to identify any underlying pathology. So what is your suspicion for a PE? Okay, let's move on. So now we go for the PLAPS point, and this is what we see at the PLAPS point for Mr. Plankton. And we can identify the plankton sign right there. So this is swirling debris agitated by cardiac and respiratory motion. And the take-home point is that it represents an exudative process here. So again, I don't know how many of these you've seen, but it's really quite interesting. I think we get more excited than the patient does about these findings, but we have swirling debris inside that pleural effusion. So that's what's hiding out in plankton right now, and that's why he feels puny. So this is an exudative process. Looking at our algorithm, then we've gone down to identify that he has pneumonia on the right-hand side, and in which case he would require a chest tube and antibiotics, of course. Using your probe. Again, the methodical approach to SpongeBob and plankton are all to identify your lung sliding, identify your profile, and then go around to that stage 3, which is your PLAPS point, and look for, and then fourthly, you can then decide to look for a DVT in the femoral and popliteal veins. That's where I kind of deviate from this algorithm because it's just more practical, if you ask me. So you say, that's cool, Dan. So what are the drawbacks to ultrasound? I mean, you've been hyping it up. It's got diagnostic accuracy of over 90%, and it's easy to use. So These are the shortcomings, which we've all seen, I'm sure. Sub-Q emphysema, air is your enemy when it comes to ultrasound, and adiposity, severe adiposity. Somebody who's calamitously obese like this is going to be difficult to image in general. Other things are like thoracic dressings or other things that kind of preclude the propagation of ultrasound beams to the lung. That's it. So again, keeping in mind those principles, things you want to look for are superficial. Anything that's going to impede your ultrasound waves are going to be pretty much up here, and that are going to impede those waves. So the main limitation of B lines is the lack of specificity. Talking about B lines, as I mentioned, they are a sign of interstitial syndrome, and therefore they're very sensitive, but they're not a specific sign of cardiogenic pulmonary edema. But it's always best to keep in mind that you need to consider everything within a clinical context. So that's my hedge, if you will, for this talk. And these are my references, and most of this is from Daniel Lichtenstein, actually. So thank you very much. Any questions, comments, concerns, or complaints?